Welcome to our discussion of the review article, The Anatomy of the Pediatric Airway. Has our knowledge changed in 120 years? Which was published in the Journal of Pediatric Anesthesia. My name is Josef Holzki, pediatric anesthesiologist and pediatric airway endoscopist, currently teaching at University Children's Hospital in Liège, Belgium. The authors of this article want to focus on important aspects of the published review containing 23 articles which can be divided in autopsy and in vivo studies which contained conflicting results. Both ways of investigation presented reproducible data, but the question remains: which methods describe the anatomy and the physiology of the pediatric larynx in the most realistic way in relation to tracheal intubation? The controversies in the literature were the reason why the authors of this review initiated their investigation. Autopsy studies from Bayeux in 1897 till Fayou in 2008 demonstrate that glottis and superior subglottis are distensible. The lumen varies from completely closed to wide open. The glottis has a triangular shape, the superior subglottic lumen is oval, the cricoid outlet is rigid, near circular and narrower than the wide open glottis and subglottis when distended with a tracheal tube or a rigid bronchoscope. This led Bayeux to the conclusion that the cricoid cartilage is unquestionably the narrowest part of the pediatric larynx. In vivo studies from Littman in 2003 till Wani in 2017, using magnetic resonance imaging, CT scans, and endoscopy under anesthesia, demonstrated a narrower glottic and subglottic lumen of the pediatric larynx compared with the rigid cricoid outlet. In some studies, they asserted that the rigid cricoid outlet might have an oval rather than a circular shape. However, the authors of the in vivo studies performed the investigations under sedation and anesthesia, partly including vocal cord paralysis. Sedation and anesthesia cause a fair amount of adduction of the vocal cords and subsequently of the distensible subglottic space superior to the entrance of the cricoid ring. This creates the impression that glottis and subglottis are narrower than the outlet of the cricoid. For sealing the pediatric airway with a tracheal tube, the correct description of the narrowest part of the pediatric larynx is of utmost importance. We need to know which is the narrowest part of the larynx when we intubate a child. The narrowing of glottis and subglottis in vivo studies is a temporary effect. After abating of the sedative agents, the lumen of the larynx changes dramatically, reaching its widest lumen when children take a deep breath. This speaks against the assertion that in vivo studies demonstrate more realistic anatomical findings than traditional investigations in autopsy specimen using calibrations and direct measurements under vision. In a study of 300 prematures and infants, the pediatric ENC surgeon Fayou demonstrated the glottis as the always largest area of the pediatric larynx below the supraglottic entrance by measuring the interarytenoid distance, whereas the outlet of the cricoid ring was the narrowest and circular part of the pediatric larynx, as documented convincingly in the review. The authors of the in vivo studies did not include Fayou's findings in their calculations. However, if we define the term circular-near circular as an AP transverse ratio between 0.91 and 1.1, the cricoid outlet is found to be circular in practically all studies. As demonstrated in autopsy studies, tracheal tubes can pass without perceptible resistance through glottis and superior subglottis to the rigid outlet and subsequently into the trachea if the circumference of the tube is not too large. This means that a well-sized tracheal tube which can seal the pediatric larynx at the level of the cricoid outlet will always be able to pass glottis and subglottis without resistance. All studies reflect the methods which were used for determining the lumen of the larynx. Therefore, it should be possible to eliminate the controversies arising from autopsy and in vivo studies by following the path which a tracheal tube takes during intubation. The temporary narrow parts of the pediatric airway under sedation and anesthesia, not seen in awake patients nor in autopsy specimen, do not impede the advancement of the tracheal tube because glottis and subglottis above the cricoid ring are distensible. This means all parts of the pediatric larynx under sedation and anesthesia, showing a narrower area of the airway compared with autopsy studies, can be opened actively by deep inspiration and passively by tracheal tubes or bronchoscopes. In conclusion, the outer diameter of the advancing tracheal tube defines where the narrowest part of the larynx is located. We want to thank the listeners for their interest in the published review.